Today we will talk about the diabetes mellitus and its management. First of all, we will define diabetes mellitus. Diabetes mellitus is a chronic metabolic disorder or it is a syndrome that is characterized by persistent hyperglycemia, that is a high blood glucose level, and the persistent hyperglycemia can either from defect in the insulin secretion or there is increase in the resistance to the action of insulin or sometimes both. They lead to the abnormalities in the metabolism of carbohydrates, proteins, and lipids. So, diabetes mellitus is a metabolic syndrome that is characterized by hyperglycemia and it occurs because of decrease in insulin secretion or increase in resistance to the action of the insulin. Next is the types of diabetes mellitus. First one is type 1 diabetes. Type 1 is the insulin dependent diabetes mellitus, and it is also known as juvenile onset diabetes mellitus. And type 1 diabetes, there is autoimmune destruction of the pancreatic beta cell. So when the beta cell are destroyed by the immune system, there will be no secretion of insulin. So there will be absolute insulin deficiency in type 1 diabetic patient, and hence such patient will require a lifelong insulin therapy. And type 1 diabetes is more common in children and young adults, and the characteristic feature of type 1 diabetes is insulinitis. Second one is the type 2 diabetes. It is also known as adult onset diabetes mellitus. And type 2 diabetes, there is increase in the insulin resistance mainly along with the progressive beta cell dysfunction. And type 2 diabetes, there is deposition of the amyloid precursor proteins, which are the beta plated proteins, and these proteins deposit in the beta cell of the pancreas and causes the pancreatic cell dysfunction. And it is most common type of the diabetes, account for about 90 to 95% of the cases, and it is associated with obesity, sedentary lifestyle, and family history. And type 2 diabetes is managed with lifestyle changes, oral hypoglycemic drugs, and sometimes when uncontrolled, we also give the patient insulin. Third one is the gestational diabetes. So gestational diabetes is the diabetes that is recognized during the pregnancy, and gestational diabetes occur because of increase in certain hormone during pregnancy, which causes the insulin resistance. And these hormones include cortisol, HCG, and the human placental lactogen. And gestational diabetes lead to the increasing risk of maternal and fetal complications, and gestational diabetes usually resolve after delivery, but it also increases the risk of type 2 diabetes development in future. Fourth one is the MODIs. MODIs stand for maturity onset diabetes in young, means that in young patient there is a feature of type 2 diabetes, that is increase in the insulin resistance. Fifth one is the LADA. LADA stand for latent autoimmune diabetes in adults. Usually in adults there is insulin resistance occur, but in such patient there where the patient is elder, there is autoimmune destruction of the pancreatic beta cell, means that in adults there are feature of type 1 diabetes and LADA. Next is the diagnostic criteria for diabetes mellitus. So criteria 1 is symptomatic patient, means that a patient having symptoms of diabetes, that is polyuria, polydipsia, weight loss, and dryness of mouth, along with the abnormal venous glucose on one occasion. A patient having the fasting blood glucose of more than 126 milligram per dl and the random blood glucose of more than 200 milligram per dl. Second criteria is the asymptomatic patient, means the patient having no symptom of diabetes, but he or she had abnormal venous glucose on two occasions, that is a fasting blood glucose of more than 126 and the RBS of more than 200 milligram per dl. And criteria 3 is a patient having the HbA1c. HbA1c per glycosylated hemoglobin, means that the amount of glucose that is bound to the hemoglobin. So if the average amount of glucose bound to the hemoglobin is more than 6.5, it also indicates this the patient is having diabetes. Next is the oral glucose tolerance test. So the OGTT is used to assess the ability of the body to metabolize the glucose, and it is used to diagnose patient that are pre-diabetic are those having the gestational diabetes during pregnancy. So, in OGTT, we keep the patient fasted for 8 to 12 hours, and we measure the fasting plasma glucose, and then we give the patient 75 gram of the glucose load dissolved in 200 to 300 ml of water, and this glucose mixed in the water is to be consumed within 5 minutes, and then we measure the plasma glucose 2 hours after the glucose load. So in a normal patient, after 2 hours the plasma glucose is less than 140, this patient is considered to be normal. But after 2 hours the plasma glucose is in between 140 to 199 milligram per dl, this patient is pre-diabetic. But if a patient having the 2-hour plasma glucose of more than 200 milligram per dl, this patient is labeled as diabetic patient. Next one is the clinical features of the diabetic patient. First one is the symptoms of diabetes mellitus. So the symptoms include frequent urination, that is polyuria, excessive thirst, polydipsia, and increase in the hunger, that is polyphagia. So we have three P's: polyuria, polydipsia, and polyphagia. Similarly, diabetic patient have unexplained weight loss, that is more common in type 1 diabetes. They may have fatigue, weakness, blowing up region, slow healing wound and sores, and patient having uncontrolled diabetes, increasing risk of infection such as skin infection, gum infection, and UTI. UTI is more common in these patients. Similarly, these patients may have recurrent yeast infection. There may be numbness or tingling in the hands and feet that occur because of the nerve damage. They are more common in long-standing diabetes. And similarly, the patient also complain of dryness of mouth and itching of the skin. Signs in diabetic patients include dehydration, weight loss, dark velvety patches of the skin in the areas of the body pores such as armpits. And this velvety patches are known as acanthosis nigricans, which indicate the insulin resistance. And similarly, in diabetic patient, there is reduced sensation in the peats, which indicate the peripheral neuropathy. Next one is the symptoms that require urgent medical attention. These symptoms include severe thirst and dehydration, persistent vomiting in a patient, deep and rapid breathing, which is known as postural breathing, and a patient having acetonic breath means that patient having a fruity smelling breath, and patient that is confused, having drowsiness or loss of consciousness. These signs are warning signs, and they indicate serious complications such as diabetic ketoacidosis, that is more common in type 1 diabetes, or hyperosmolar hyperglycemic state, that is more common in type 2 diabetes. Next is the management of the diabetes mellitus. First, we advise the patient conservative treatment, in which we advise dietary management, and we advise the patient to consume a balanced diet along with controlled carbohydrate intake. We advise the patient to avoid refined sugar and prefer the complex carbohydrates that contain the starch, such as whole wheat, brown rice, and the oat. Similarly, we also advise the patient to increase the dietary fibers such as vegetables, fruits, and having low glycemic index legumes, and also um, include in the diet the lean proteins that are present in the fish, chicken, eggs, and pulses. Choose or consume the healthy fat such as present in the olive oil, nuts, seeds, and avoid the trans fats. Limit the sugary drinks, sweets, desserts, and the processed food. Also reduce the salt intake, especially in patient having hypertension and diabetic. Also, we advise the patient to eat small, frequent meals and avoid skipping up the meal. Maintain adequate hydration, and if the patient is overweight or obese, we advise them to reduce his weight by 5 to 10%. Second one in the conservative management is lifestyle modification, in which we advise the patient to have regular physical activity or exercise, um, We also advise the patient to achieve and maintain a healthy BMI. If a patient is doing smoking, we ask him or her to quit smoking. We also advise the patient to avoid the alcohol and have also advise them to have adequate sleep, that is 7 to 9 hours sleep per night. Mm. Still, with conservative management, if the blood glucose level is high, then we advise the oral hypoglycemic drugs. And oral hypoglycemic drugs are mainly given in type 2 diabetes. These drugs include different classes which have different mechanism. First one is the drugs that increases the um, sensitivity, that is the insulin sensitivity. So the drugs that causes increase in the insulin sensitivity include metformin is a biguanide. Second one is the thiazolidine diones. They include pioglitazone and the rosiglitazone. So these drugs causes increase in the insulin sensitivity to the tissue. They also inhibit the hepatic gluconeogenesis so that no new glucose is pumped. And the thiazolidine diones, they cause activation of peroxisome proliferator and activator receptor and causes increase in the insulin sensitivity. Metformin causes lactic acidosis. It is the most common complication of the metformin, and it is frequently asked in the vivas and exams. Thiazolidine diones causes GI upset and also weight loss. Initially, the metformin was considered as a weight loss drug, but now it is considered as weight neutral. Second one is the drugs which causes increase in the insulin secretion from the pancreas, in which the first and most common one is the sulfonylureas. Sulfonylureas include first generation, that is fluropropamide and tolbutamide. Second generation include glipizide and the glyburide. And second one, and insulin secretion drugs include meglitinide, that is the netiglinide. These drugs causes the closure of potassium channel in the beta cell. So when the potassium channels are blocked, potassium is a positive ion, and the positive ion is collected inside the cell. So they causes the influx of the calcium ion, and there will be calcium dependent release of the insulin from the pancreatic beta cell. So these drugs causes the release of the insulin from the pancreatic cell, but the adverse effect of these drugs include weight gain, edema, and the heart failure. Next one is the drugs that causes increase in the glucose dependent insulin release. Means that there will be increase in the insulin secretion. They include glucagon like peptides analogs, means the GLP-1 analogs. They include exenatide and liraglutide. And next one is the dipeptidyl peptidase 4 inhibitor. Normally, the dipeptidyl peptidase enzyme, they causes decrease in the GLP-1 secretion. So when we block this enzyme, there will be increase in the GLP-1 concentration and will cause increase in the insulin secretion. So the dipeptidyl peptidase inhibitor includes sitagliptin and saxagliptin. The mechanism of action of this drug is they cause decrease in the glucagon release. So when there is a decrease in glucagon release, there will be no gluconeogenesis, no lipolysis, and no proteolysis, and the level of glucose will decrease. Similarly, they also cause decrease in the gastric emptying, and hence causes more stimulation of the intestinal cell to release GLP-1 and causes insulin secretion. So hence they will lead to the increase in the glucose dependent insulin release. The GLP-1 side effects include pancreatitis, weight loss, increase in the satiety, whereas the dipeptidyl peptidase 4 inhibitor, they causes increasing risk of respiratory and urinary tract infection. And these drugs are weight neutral drugs. Next one is the drugs that causes decrease in the glucose absorption. First one is the sodium glucose co-transporter inhibitor, that is SGL2 inhibitors. They include dapagliflozin and empagliflozin. Normally, SGL2 is found in the intestinal brush border cell, and when we block this co-transporter, there will be decrease in the carbohydrate or the glucose absorption. The adverse impacts include dehydration and the increasing risk of the UTI. Remember, the empagliflozin is associated with increasing risk of the UTI. Next one, in the decrease in the glucose absorption drugs include alpha glucosidase inhibitor. This is an enzyme found at the level of intestinal brush border, and this enzyme causes the breakdown of complex carbohydrate and causes glucose absorption or increases the glucose absorption. So when we inhibit this enzyme, there will be no hydrolysis of the carbohydrate, and there will be decrease in the carbohydrate hydrolysis and its absorption. And they include egg carbose and migritol. And the alpha glucosidase inhibitor, they also causes dehydration, increasing risk of UTI, and similarly they also causes hypoglycemia. Last one include the amylin analogs, in which the most important one is pramlintide. The amylin analogs causes decrease in the glucagon release, and they also cause decrease in the gastric emptying, but the adverse effects include hypoglycemia and increase in the satiety. So the drugs, the oral hypoglycemic drugs include drugs that causes increase in insulin sensitivity. They include metformin, tizolidine, diophons, that include pioglitazone, rosiglitazone. Drugs that cause increase in insulin secretion, that is sulfonylureas, in which there is first generation and second generation, and they also include the meglitinides, that is natiglenide. Third one is the drugs that causes increase in the glucose-dependent insulin release. They include GLP-1 analogs like exenatide, liraglutide, and the dipeptide L-peptide OS4 inhibitor, that is the sitagliptin and the saxagliptin. Next one is the drugs that causes decrease in the glucose reabsorption. They include SGL2 inhibitor, that is dapagliflozin, empagliflozin. Empagliflozin is associated with increasing risk of UTI, and the alpha glucosidase inhibitor, that include acarbose and the miglitol. And last one is the amylin analog, in which the first and most important is the pramlintide. Next is the management of a patient of type 1 diabetes. So for type 1 diabetes, we only give insulin, and the insulin is given lifelong. And insulin, we know that insulin is an anabolic hormone. Um, it may causes the weight gain. The type of insulin include ultra short acting, that include Lispro and Aspart, and they work about 2 to 4 hours. Second one is short acting insulin, that is the regular insulin. Remember, regular insulin is very important, and it is a short acting insulin, and it is a duration of about 5 to 8 hours. Third one is intermediate acting insulin, that include NPH, that is the neutral protamine heterog, and lenti, and they work about 7 to 14 hours. And the fourth one is the long acting insulin. A long acting insulin is given as a basal insulin, because it provides coverage for about 18 to 24 hours. And the long acting insulin include glargine, tritimar, and ultra lenti. So the insulins include ultra short acting, that is less for aspart, short acting, that include the regular insulin, intermediate acting, that include NPH and lenti, and the long acting insulin, that include glargine, tritimar, and the ultra lenti. Next is the regime for the insulin administration, means that how will we administer the insulin to a patient. So we usually start the insulin with a conservative or small dose, and then adjust the insulin according to the patient glycemic control. And most of the type 1 diabetic patient, they require insulin of about zero point 0.5 to 1 unit per kg per day. We have two regime. First one is the for the insulin administration. First one is the twice daily regime, in which we give the insulin 2 times a day. And twice daily regime include the injection of short acting insulin and the intermediate acting insulin, and they are given in a combination of 7:30, means that such combination includes 70% of the NPH and 30% of the regular insulin. And we give this regime before the breakfast, and then in the evening meal, means that it is given 2 times a day. And two-thirds of the daily requirement of insulin is given in the morning, and the remaining one-third is given in the evening. And remember, the insulin is also given before the breakfast or before the meal. Second regime is the intensive insulin therapy, which is also known as the basal bolus insulin. So the basal bolus insulin involves the injection of long-acting insulin, that is the ultra lenti. So long-acting insulin act as a basal insulin that provide coverage. you know, 24 hours, and this basal insulin is given once daily in the evening, and it also includes the regular insulin, and the regular insulin is given 3 times a day, and it is given before each meal, that is 30 to 45 minutes before each meal, and should be adjusted according to the preprandial glucose measurement. So in intensive insulin therapy, we give basal insulin, that is the long-acting insulin that provide coverage for 24 hours, and it is given in the evening, and we give regular insulin, which is given as a bolus insulin, and it is given before each meal. And to calculate the insulin dose, let's suppose if a patient has a 60 kg of weight, so we divide it by 2, so it comes as 30. So we have to give the patient 30 units of insulin. So in 30 units, half of the dose is given as the basal insulin, that is the long acting insulin. So 15 will be given as a basal dose, and the remaining 15 are given as a bolus dose. Means that the remaining 15 units are given before each meal, such as we give in the breakfast, then in the noon time, and then in the evening time, that is a 5 and 5 unit of insulin. So we divide the weight by 2, the figure which come, then that is 30, and we divide this 30 into 2 half, where the first one is 15, and second is also 15 units. So the first 15 units are given as a long-acting insulin, and the remaining 15 are given as a bolus insulin before each meal. Last one is the complication of diabetes mellitus. So diabetes mellitus and mellitus complication are divided into two main groups. First one is the microvascular complication that involve damage to the smaller blood vessel, and these complications include diabetic retinopathy, nephropathy, and the neuropathy. In diabetic retinopathy, there is a damage to the small retinal blood vessels, and they have different phases such as non-proliferative phase, in which we have microaneurysms occur, hemorrhages occur, that is dot and blot hemorrhages and exudate occur. Then we have the proliferative phase, in which there is new vascularization occur, which leads to vitreous hemorrhages and blindness. And then we have the macular edema, which causes visual impairment. So in diabetic retinopathy, there will be damage to the small blood vessel of the retina, and may lead to the blindness. Second one, in microvascular complication in nephropathy, in which we have the glomerular damage occur and will lead to the loss of albumin in the urine, and there is progressive decline in the GFR. And the earliest clinical sign of nephropathy is the microalbuminuria, means that there will be a loss of albumin in the urine. And diabetic nephropathy may progress the patient toward the end-stage renal diseases. And diabetic nephropathy is usually associated with hypertension. And diabetic nephropathy, the histological feature is the Kymelsine-Wilson nodule, means that there will be nodular sclerosis and the glomeruli occur. Third one, in the microvascular complication is diabetic neuropathy. Neuropathy means that there will be damage to the nerves occur, and diabetes, the high glucose level in the blood, that causes damage to the small blood vessels that supply blood to the nerves, that is the vasa nervosa, which are damaged due to high glucose level with time. And the diabetic nephropathy may involve the motor nerve, sensory nerve, or the autonomic nerve. The sensory nerve are most commonly involved. And diabetic neuropathy is classified as somatic neuropathy or autonomic neuropathy. Somatic neuropathy include mononeuropathy that involve damage to a single nerve, that is when median nerve is involved, that causes carpal tunnel syndrome. Polyneuropathy, multiple nerves are involved. A polyneuropathy may be symmetrical, means that it involves the both sides, and the symmetrical polyneuropathy mainly involve the sensory nerves, and they involve the distal part of the body. And the second one is asymmetrical polyneuropathy, means that it involves unilateral side, and the nerves involved are mainly motor, and they are proximal. So symmetrical polyneuropathy involve the sensory nerve and they are distal nerve, and the asymmetrical polyneuropathy mainly involve the motor nerve and they are proximal nerve. And in diabetic patient, there may be damage to autonomic nerves that causes increasing risk of portal hypertension, erectile dysfunction, resting bradycardia, and the gastroparesis, means that there decreases the gastric emptying. Next is the macrovascular complication of the diabetes. In macrovascular complication, there is accelerated arteriosclerosis, that is a thickening and hardening of the large and medium-sized arteries, and hence there will be decrease in the blood supply. toward the major organ. And the macrovascular complication include coronary artery diseases that include angina, MI, heart failure, cerebrovascular diseases that include TIA and ischemic stroke, and the peripheral arterial diseases that include intermittent claudication. Claudication there is a decrease in the blood supply and arteries, and they causes severe pain. Similarly, they causes poor wound healing. There may be diabetic increasing risk after diabetic foot occur and diabetic foot ulcer occur, and there's an increasing risk of the gangrene, which will lead to the amputation of that organ, that is the foot. So it was all about the diabetes mellitus and its management and the complication. Now at the end, let's read a scenario. That is a 52-year-old, that is female and obese patient who presented in the endo OPD with a chief complaint of fatigue, polyuria, nocturia, and increased urinary frequency. So these are the symptoms of diabetes. And similarly, this patient is bilateral leg swelling and blurring of vision, means that she had also developed retinopathy, and numbness in the lower limb bilaterally, means that she is symmetrical polyneuropathy. She also will report recurrent UTI history and has weight loss of 5 kg. On examination, she is hypertensive, and the BMI is 32 kg, means that she is grade 1 obese patient, and she had bilateral pitting edema, and the urine depth check they shows plus 3 proteinuria, means that she had also developed nephropathy also, and glucose in the urine, while her RBS is more than 320 milligram per day. So in diabetic patient, the RBS is more than 200 milligram. In this patient, RBS is 320 milligram. So she is a type 2 diabetic patient who had developed uh, long-standing complication like neuropathy, nephropathy, and the retinopathy. So it was all about the diabetes.